Well, good morning, everyone. As you can see, I've been given a historical task. I'm to tell you about warfarin, and I imagine you know everything there is to know about warfarin already. So it will be a revision to start the day. Of course, before I get going, I have to show you that I have some competing interests that you should bear in mind. Many are academic, others are financial, so bear this in mind. Now, let me start off with where did warfarin come from? In the 1920s and the 1930s, there was an epidemic of hemorrhagic disease in cattle in North America and Canada. And one day, a farmer who had a prize bull that died of a hemorrhage took this dead bull and a bucket full of blood that wouldn't clot to Wisconsin, to the so-called Wisconsin Alumni Research Foundation. And those are the first four letters, obviously, of warfarin. And it wasn't until some 8 years later, in 1941, that Carl Paul Links identified the problem. It was in the silage. It was part of the clover that was being eaten by the cattle and by this bull. Now, as well as showing you where the name comes from, I want to point out to you a few salient dates. First of all, this drug, this agent, became available as a rat killer in 1952, and it wasn't until 1954 that it became available as a medication for human beings. It took just 2 years to approve warfarin on the basis of practically no clinical evidence whatsoever. But of course, this evidence did begin to accumulate, and George Hart published this famous meta-analysis of the efficacy of warfarin. You should notice that there were 6 trials, less than 3,000 patients. You can see from the forest plots that the point estimate in every trial favors warfarin, and that in meta-analysis there was in fact a 64% reduction in the likelihood of stroke compared with placebo. Now, that figure is pretty well known and it's pretty impressive. What most people don't know is that in addition to that, there was a 26% reduction in mortality. Now, that is a highly effective drug. There's no two ways about it. And I want you to understand that efficacy, because during the day we will be comparing new therapies to this old therapy. And you have to remember that any effect seen with the new therapy is on top of these effects seen with warfarin. So let's actually see what the clinical results nowadays are with warfarin. This is a publication from Circulation by Freiburg. It describes data coming from Sweden. There are 4 graphs. The graphs go vertically from a low risk of bleeding to a high risk of bleeding, and horizontally from a low risk of thromboembolism to a high risk of thromboembolism. The endpoint that's being plotted is all-cause mortality plus ischemic stroke plus intracranial bleeds, and the patients are divided into those taking vitamin K antagonists and those not. We don't need to look at the detail of the graphs. You can see that in every instance, in all of these 4 circumstances, warfarin beats the no anticoagulant. Now, of course, it's not randomized studies, but these are from administrative databases. And you can see, however, that the hazard ratios are astounding. From 26% to 72%, notice all of these axes come down to 0. These are not tiny effects. They're not gee whiz effects. They're very, very strong effects. Now, unfortunately, given all that data about how good warfarin is, it's a shame we cannot use it. Here is some data of patients who are being cared for in primary care. They all require antithrombotic treatment. You can see that nearly 2/3 of them don't get any warfarin. The third that do get warfarin, only about 1/3 of them are in the therapeutic range with warfarin. So that briefly describes the state of play. You can see that this was published in 2000, but believe me, it's no different today. Let's have a look at one of the main reasons why people don't get treated with warfarin. The main reason is probably that patients are judged to be too old. Now, later in the day, you will be told that age is perhaps the single most important risk factor for thromboembolic stroke in patients with atrial fibrillation. So it's really disappointing that patients who are 85 or older at most are exposed to vitamin K antagonists in 20% rate. If you're younger, where you don't have such risk, of course, you may get warfarin prescribed in up to 80% of younger patients. But even if you get prescribed the drug, you can see that by 3 years, half the patients have stopped taking it. So it's not used very much at all. And when it is used, as that previous slide suggested, it is often not used correctly. In other words, the dose adjustment of the warfarin is not sufficiently accurate to keep the INR within the range of 2.0 to 3.0. Now, here are some data from the US, and you can see that in the community physicians' hands, the average time in the therapeutic range from this meta-analysis of about 7 or 8 studies is 51%. Now, does that make a difference in terms of averting stroke? Well, I think you can see it does. If the patient is anticoagulated correctly for 71% of the time or more, you can see that there's something like a 3 or 4% stroke rate at 3 years. If it's 51%, let's call it this brown line, you can see that the stroke rate at 3 years is 20%. And in fact, if you have times in the therapeutic range which are, for example, less than 50%, you can see that it's not even as good as not giving warfarin in the first place. Because, of course, the INR is both above and below the line, and bleeding is much more common if you over-anticoagulate patients. Now, can we keep the INR in the normal range? For this purpose, I've just chosen to show you some data from a clinical trial. It comes from the RELY trial. I'll be talking about dabigatran later, but you can see that all around the world there were very variable options or success rates in maintaining the INR in the correct therapeutic range. So in the United States, it came out at 66%, rather better than the real-world data that I showed you a little while ago. In the UK, it came out at 72%, which I think is roughly equivalent to the real world in the UK, because we have very careful controls on this in the UK. But you can see we're beaten pretty solidly by Sweden, that came in with 77%. Now, one of the ways in which we might consider trying to improve time in therapeutic range is to do some genotype testing. Now, this is in the label for warfarin in the United States. It's not in Europe, but increasingly people in the United States have been doing genotyping. These data actually, though, come from the United Kingdom in an MRC-funded study that was reported just a few weeks ago. I'll remind you that the INR is affected by drug interactions, by the status of the CYP2C9 enzyme system, the status of VCORP1, and factors such as the age and the height and the weight of the patients. In this study that was reported at the AHA, we can see that the time in the therapeutic range could be increased from about 60% to about 67%. A 7% increase, that makes a significant difference in terms of potential stroke rates. But of course, this is a relatively expensive technology, and in the UK, we're probably not used to it. I have to tell you that the very next talk at the AHA tried to do a study in the US, and they got contrary results, largely because they didn't have the results of the genotyping when they started treating the patient with warfarin. And that's what the genotyping is for, in order to adjust the starting dose of the medication. So genotyping is one option. Another option is to use patient self-testing. Now, I don't know how many patients you have who have the coagulometers. I must have about 20 or 30 of them who are testing warfarin for themselves. And this has tremendous advantages, particularly if people have irregular lifestyles. So the people who get up at the same time every day and go to bed at the same time of day and eat the same kind of diet every day probably don't need to frequently test their INR. But the people who do different things every day and travel a lot, for example, probably can be advantaged considerably by using patient self-testing with a small coagulometer. And these data show from studies in the USA, and this is a meta-analysis in which the endpoints were thromboembolic events, we can see a reduction of about 40% in major thromboembolic events by using patient self-testing. So this is a very good technique, and I strongly recommend it for patients on warfarin that have very irregular lifestyles. And some of them can certainly afford to buy one of these coagulometers. They're only a few £100, and they can save themselves from a lot of unnecessary stroke. Now, one of the other ways in which we're seeking to try and help patients who are taking warfarin is not to keep taking them off warfarin and restarting them on warfarin when they undergo procedures of various kinds. Here I'm illustrating just using an ablation procedure, but it could be minor surgery, it could be putting a pacemaker in, or what have you. It's not necessary in low bleeding risk situations to stop warfarin. In fact, stopping warfarin, bridging with low molecular weight heparin, restarting warfarin turns out to be much more hazardous. As you can see from here, major bleeds and tamponade were much more common in the patients who had interrupted rather than continuous warfarin. And that is no surprise. What is a surprise is the stroke rate, for example, was so much higher in those who discontinued warfarin. But that's another device to try and improve matters. But there is a big problem with warfarin, which is centered on the fact that no matter how well you control it, you cannot prevent intracranial hemorrhage. Now, this shows you from this cohort of some 1,500 patients that nearly 70 of them were taking warfarin when they had an intracerebral hemolysis, an intracranial bleed. 42 was intracerebral, and you can see that of those patients, just over half of them were actually in the therapeutic range when they had their intracranial bleed. So you cannot completely avoid intracranial bleeds, no matter how carefully you titrate the warfarin. And this, of course, is a particular problem in older patients. We can see from any number of studies, and I showed you one pie chart already, suggesting that we don't use warfarin very carefully. Here's some histograms showing that European-wide, in the European Heart Survey, patients at low risk are overtreated with warfarin. That's the gold bar, and patients at higher risk are undertreated with warfarin. And the consequences of doing this are seen on this slide, also came from the Euroheart survey, that obviously the stroke rate is going to be too high with undertreatment, and the bleeding rate is going to be too high with overtreatment. And if you look at the composite, you can see that you do much better if you're treated and maintained in the therapeutic range than if you're allowed to stray outside. Now, what is the alternative to warfarin? Many doctors are encouraged to think that aspirin is a good alternative. Now, that in the UK, that largely comes from a rather silly arrangement for paying doctors extra money for recognizing atrial fibrillation and then starting them on antithrombotic therapy, aspirin or warfarin. Now, it's much easier to take aspirin out of your pocket and give it to them than get them started on anticoagulants. So what do GPs do in the UK? Well, here you see it from the GP research database. These patients are divided into those at low risk, going to patients at high risk of stroke. They all have atrial fibrillation. You can see the rate of anticoagulation is more or less even at around 35% at most, whereas the use of antiplatelet drugs, and this is predominantly aspirin, goes from 40% at the low risk cases to nearly 85% at the high risk cases. This is completely wrong. Absolutely the wrong thing to do, and yet it's happening today. These data were published in 2011, collected in 2010, and it's not a bit different today compared with then. On what basis is anybody recommending aspirin? Well, this is the basis, and again, it's a meta-analysis from Bob Hart. I showed you one to begin with regarding warfarin. Here's one regarding aspirin. And you can see the situation is entirely different. If we look at all the aspirin trials combined, we see that the point estimate for a reduction of strokes about 18%, but the upper limit of the confidence interval breaches the line of unity. In other words, it's not even statistically significant. If we add some other antiplatelet drugs into the mix, we can make it significant with a point estimate of 22% reduction. Compare that with 64% reduction. Not very good. And that's the best that can be claimed for aspirin. And let's see where the problems began to set in. The problems started when the Japanese did a trial. And the Japanese did a trial of aspirin because most of their physicians like using aspirin. So they randomized patients to aspirin or no treatment, and they followed them. And you can see they didn't get very far looking at stroke rates because clearly aspirin had more stroke rates than not doing anything at all. So that quickly convinced the Japanese that they were doing the wrong thing. At least it convinced their guideline writers, but unfortunately it didn't convince their doctors because they're still using aspirin exactly the same high rate. What about us? Well, we have study in England called the Birmingham Atrial Fibrillation Trial in the Aged, or BAFTA. Here, aspirin and warfarin were compared in a randomized fashion, and you can see that those patients taking warfarin did roughly twice as well as those patients taking aspirin with regard to these endpoints of intracranial hemorrhage and disabling or fatal stroke. You can see that the hemorrhage rate was more or less the same. Now, is that a surprise? Is it a surprise to you that if you take aspirin and you take warfarin, the likelihood of having a bleed is the same with aspirin as with warfarin? Very important concept, but it's been shown time and time again. And if we look at this trial, this is the Averroes trial, where we're comparing not with warfarin, but with one of the so-called NOACs, more of that later, we can see that apixaban, in this case, did really well against aspirin with a relative risk reduction of 55%. This trial didn't even go to a conclusion. You can see why not, because aspirin was clearly highly inferior to apixaban, but the Data Monitoring Board stopped the trial. They knew by 6 months they had to stop it, but since there was no alternative if they stopped it but to stop apixaban, because there was no other apixaban available, they allowed the trial to continue until apixaban had been made available for people who stopped the trial. In fact, they were somewhat duped because the apixaban wasn't ready even when they stopped it. So the patients who were taking the apixaban in many cases had to swap to taking aspirin because they were patients who couldn't take warfarin. That's why they're in the trial to begin with. Right. Well, if aspirin is no good, what about the combination of aspirin and clopidogrel, dual antiplatelet therapy for atrial fibrillation? Well, we see again a failed trial because we can see that clopidogrel plus aspirin was associated with more of the primary endpoints, which were essentially stroke endpoints and bleeding endpoints, than were the oral anticoagulant, vitamin K antagonist, and you can see that the bleeding rates were much the same. So this trial didn't satisfy any criteria, and clearly dual antiplatelet therapy is not anything like as good as oral anticoagulants. But what about a trial not of warfarin against the two antiplatelet drugs, but just aspirin against the two antiplatelet drugs? And here you see that the double antiplatelet therapy is somewhat better, rather less ischemic strokes, but unfortunately rather more major bleeds and intracranial bleeds. If we actually look at the balance, we'll see that for every 1,000 patients treated for 3 years, it would prevent 28 strokes and 6 myocardial infarctions, but we'd have 20 major bleeds. 7 fatalities against 3, admittedly, and so the therapy is worth considering, but it's not as good as we would like. There have been attempts to try and derive a good estimate of what the net benefit would be. If you have bad things and good things, is a bleed the same as, for example, a myocardial infarction or a stroke? Well, not necessarily. And Rafe de Caterina tried to work out how bad these things were by seeing what percentage of them ended up with death. So stroke, 23%, will have death, for example, myocardial infarction, 23%, and so on. He developed adjusted relative risks and applied this to net clinical benefit. And when he did that, you can see that by and large, clopidogrel plus aspirin is better, and in most instances statistically better, than aspirin alone. So the conclusion could be that dual antiplatelet therapy is worth considering if you have no other option, and certainly it's better than aspirin alone. Now we have to ask, why do doctors not use warfarin? So here's a survey that was done asking both general practitioners and cardiologists, why do you not use warfarin? And the interesting thing was that in nearly a quarter of the patients, or a third of the patients, with regard to GPs, and something similar with regard to cardiologists, there was no indication. That actually means no reason. In other words, when the doctors were asked, why didn't you give warfarin, they had no idea why they didn't give warfarin, which is an amazing thing to say straight away. Patient refusal was relatively small. Fears about compliance, interestingly, were relatively high. And if you fear compliance, then there is no alternative in terms of NOACs to replace warfarin, because the compliance problem is even worse with NOACs. I don't mean people are not as compliant, but if they are not compliant, it's a worse problem. People being afraid of hemorrhage is a very high risk factor. And then you can see there's a whole range of particular issues. For example, fear of falling, the fact that patients living alone, previous bleeding history, etc. Now, if we actually look at another piece of data, looking why people were selected for active W, that's the warfarin comparison with aspirin and clopidogrel, rather than why they were selected for active A, that's clopidogrel and aspirin versus aspirin, rather than the comparison with warfarin, we see that the majority of the reasons were that the patient was unwilling to take the oral anticoagulant, or the physician thought that the oral anticoagulant was inappropriate. So it's all really to do with conception rather than anything much more serious. So we have to ask, is warfarin obsolete? Well, hardly. There are currently 0.36 billion prescriptions of this drug every year worldwide. And you can see that it's being used significantly, although the number of visits resulting in warfarin prescription are falling in the United States as other drugs, in this case, the only drug that was available at the time was dabigatran, was increasing. But there is a continuing role for warfarin, particularly if there's a risk of non-compliance, when there's renal impairment, when angioplasty and stenting is considered, although many are now moving to doing that without any data on the novel oral anticoagulants. When there's a mechanical heart valve, and I'll tell you more about that later, when the patient has hypertrophic cardiomyopathy, perhaps, when the patient is a child or an adolescent, because there are no data available in children and adolescents with NOACs, when the drug needs an antidote, not that warfarin is particularly good in that regard, vitamin K doesn't work very quickly, or if the patient's intolerant to the new drugs. But you'll see I've circled 3 of them, which I think are really important. One is non-compliance, and we don't pay that enough attention with regard to the NOACs. The other is mechanical heart valves, where we have pretty solid evidence for the time being with at least one of the NOACs that it didn't do well, and where cost is an issue. And those of us who work in London know that this is one of the dominating issues and why we have to prescribe warfarin to all patients, and it's only if they fail warfarin that they can be considered for other drugs. Now, NOACs. We're going to hear a lot about NOACs this morning. They used to stand for new oral anticoagulants, but drug companies can't use the word new after 12 months, so it was rechristened novel. You can get away with novel, but that's wearing a bit thin because some of these drugs have been around for a few years now. So people are now thinking of different acronyms, and one favorite is DOACs, direct oral anticoagulants. Another favorite is target-specific oral anticoagulants, although I find it difficult to pronounce TOSOACs, but some people like that. But I think what we're actually going to end up with is NOACs, but now standing for non-VKA oral anticoagulant. So that is what we have to do from now on, probably. And we have 4 of these NOACs. I'm not going to talk in any detail about them, simply to say that they have substantial differences, their trials are substantially different, and we will hear about them all one by one today. I'll just show you the guidelines of the ESC. These will be described to you in greater detail today, but briefly I want to point out that in these guidelines, as in almost every other guideline worldwide, NOACs, novel oral anticoagulants or non-vitamin K antagonists, are preferred to dose-adjusted warfarin in patients who require anticoagulation for stroke prevention in atrial fibrillation. Thank you very much.